Recording is in progress. Thanks, Gillian. I am Kelsey Brakel. I'm going to present the first two cases, and then Gillian, and then Megan. So we shall begin. The first case is Baxter. Baxter is a 2-month-old intact male Boston Terrier. We got Baxter's left eye. What they told us was that the eye was non-visual. There was an 8mm perforation with iris prolapse surrounded by granulation tissue. There was anterior synechia, and they couldn't see the retina. They said there was no glaucoma, and they said that there was a history of unknown trauma that caused the perforation. So when we got the globe, we described a protruding axial dark spot in the cornea, which you can kind of see here, right there. It's a little bit difficult to see in the section that we have. And we don't have a great example of it in the histology slide either. So you'll just have to imagine it in your head. But obviously the globe is quite large. We said it was ophthalmic. The cornea is up here. The little nubbin of optic nerve is down here. There's no anterior chamber here that you can see. So all of this brown tissue is mostly iris that's plastered against the posterior aspect of the cornea. And that plastering has made the anterior chamber vanish. You'll also notice there is no lens. This is not because we put it in the other half or because we lost it in some fashion. It's just not there. We didn't see it when we cut open the globe, and we didn't see it histologically either. We also said that the retina was detached, which is honestly extremely difficult to appreciate in this section because it's kind of hard to see where the retina is at all. It might be that this is ribbons of folded retina here. In which case we also said that it was torn, and you can maybe see these like scallopy edges. And that's pretty much all that we said about what was happening with this eye grossly. So we will switch to the slide. It is weird. I don't know why that is like that. If anybody knows how to fix that, feel free to fiddle, but I am unaware.
Here.
Don't mind us.
Click fit to window.
We're
And now
struggling.
There you go.
All right, great. Okay, here we go. All is well. All right, so here's our globe. Let me get this guy in focus for Gillian's joy and happiness. All right. Oh yeah, thank you. We'll put the mouse in the middle. All right. We're real organized today. Having the advanced technology of the microphone has thrown us off. So the cornea is here, or what's left of the cornea. There isn't an anterior chamber, as we saw grossly. There's this sort of loose pigmented tissue, which is gonna turn out to be iris plus minus some ciliary body that's, like we saw grossly, plastered against the surface of the cornea. And so there's no anterior chamber anymore. The cornea goes back sort of as you might expect, probably about to here, where we've got limbus. Everything near the limbal sclera is really thin, which is consistent with the ophthalmos. Here's retina. Retina's definitely here. That's good news. It's got these little curly ends that are kind of blunted, which is consistent with tear. And then obviously it's also detached, and we'll go closer and confirm that that's real. They said there was no glaucoma, but the little bit of optic nerve that we have back here looks like maybe there's some atrophy of the optic nerve head. It's not really flush with the choroid. And that's about it. There's no lens. And in general, there's just big wide open spaces inside that eye. All right. Oh, it's so sticky. Oh my gosh. All right. So we'll go ahead and start here, because this is kind of perplexing and interesting. So, cornea is here. There's some corneal epithelium here. It's kind of thick. Cornea stroma is extremely dense. It's the collagen is a little bit less organized and a lot thicker than we normally expect. And then here is that iris tissue that's plastered against it. There is some muscle here, which lets you be a little bit more confident that this is actually iris and not random chunks of uveal tissue. But other than that, there's not a lot of normal anatomic distinguishing features. If we go a little bit closer. Thank you. So again, here's our cornea. If this is cornea and this is iris, there ought to be Descemet's membrane here, which there is strikingly not. And Descemet's membrane is not here for a very, very long time. Eventually, you come to areas like this, where you've got this nice, very, very thin, homogeneous eosinophilic band, which is a basement membrane, which is what Descemet's membrane is. It's really, really thin because remember, this dog is only 2 months old. And so its basement membranes aren't that thick yet because it hasn't been making them for very long. So Descemet's membrane is going to be quite thin. But then it's all coiled up here and bundled up in all of this sort of fibrous connective tissue that's creating this sort of connection between the cornea and the iris. So this is indicative that at one point Descemet's membrane broke and then kind of coiled up on itself and springed back. And so this is sort of one end. There are other areas where it's also broken, but that's the most like exciting example of where it actually broke as opposed to just disappeared. You can continue to follow Descemet's like this, and then it becomes absent, and then it picks up again here, and then it becomes absent again. So Descemet's membrane is multifocally discontinuous. The cornea contains a lot of blood vessels, like we already talked about. There's some increased cellularity, and the epithelium is hyperplastic. A lot of this is just reactive change due to the fact that we've got thalamus and probably some exposure. There's some keratitis. But then also we've got this pretty significant corneal stromal sort of fibrosis and increased density, especially in areas where the iris is plastered up against the cornea. Like I said, we don't have the place where they described iris prolapse, but you can imagine how if Descemet's is gone and the iris is stuck to the cornea, there's probably a spot where it's poking through based on the gross photo that we have. Like I said, we don't have lens. If we go posteriorly, we'll find it someday. There's retina back here. That's what we're going for. All right, here's retina. The retina is detached. So the other thing that's going on in the retina, so we have these sort of big clear spaces within the outer, sort of separating the outer nuclear layers. And these big clear spaces, we call this entire process retinoschisis. This is something that we associate with trauma. We see it sometimes with traumatic detachment of the retina. And then there's also sort of absence of ganglion cells in here. So a lot of the layers are still present. We've got inner and outer nuclear layers here, but there's no ganglion cells really to be seen along most of this retina. So there's some retinal atrophy as well. And then if we go back to the optic nerve that we talked about on subgross, there's a little bit of optic nerve atrophy, which makes sense, right? Because the entire anterior chamber is collapsed. We don't really have a drainage angle anymore at all whatsoever. So it's not surprising that we're developing glaucoma and some optic nerve atrophy associated with that. Here we've got RPE, retinal pigmented epithelium, that's becoming hypertrophied. So cells are getting big and fat, and they're reaching up to the sky, trying to grab back onto the detached retina, which they'll never succeed in doing because it's just too far away. They're separated forever. And I think those are all of the salient things about this case. Yeah. Right, we'll go back to the gross photo. So we had a lot of sort of specific diagnoses for this case, but our big umbrella diagnosis that encompasses a lot of all of this is early life trauma / anterior chamber collapse syndrome. We use the terms interchangeably. So this is a diagnosis that we make when we see multiple breaks in Descemet's membrane, usually very broad areas of Descemet's membrane absence. Broad anterior synechia where the iris is adhered to the cornea in those areas of absence. And then aphakia, so no lens inside of the globe. And we assume that that's due to the lens being extruded during the trauma rather than there never being a lens at all. We don't know for sure sort of why this happens. We speculate that maybe this is due to some kind of trauma extremely early in life, possibly even before the eyelids open and separate. So there's frequently there's relatively minimal inflammation associated with this. A lot of times, in this case, there was a clinical description of an actual perforation. A lot of times we don't get that. We often just get a extremely ophthalmic globe in a young animal, and when we open it up, there is no more anterior chamber. And we assume that there was previous perforation and then extrusion of the lens and then sort of everything sealed back over again. And then obviously there's collapse of the angle and glaucoma. So that's this case. It's a pretty good example. And it's nice to kind of have one where we see all of the features of anterior chamber collapse syndrome in conjunction with an actual perforation before it had time to heal.
I assume that the clinician said no glaucoma based on a normal IOP. Given the hugeness of this globe, obviously there was something instigating ophthalmos, which would have been lack of aqueous humor outflow and increased IOP in a young animal, which has a very stretchy iris or sclera rather, causes marked ophthalmos, and maybe the stretchiness prevented an actual high IOP being measured by a tonal pen or something.
They said the IOP was 18. So
Yeah, that optic nerve
reasonable.
also looks very wide, which is I think another suggestion that the stretchiness of the sclera is being not only cut, but right.
Okay. Feel free to put your questions in the chat for Gillian. Our next case is Blackie. Blackie is a 10-year, 8-month-old neutered male domestic short-haired cat. We got the left globe. They described a raised iridoid mass, temporally and nasally. So like both sides of the iris, I guess. Possibly the whole iris if you're looking ahead at the gross photo. They also described, yes. Oh, I'm blocking the microphone with the paper. I see. I'm sorry, everyone. They also described hypopyon and hyphema. And then they described the iridoid mass again, in case perhaps we missed it the first time. They also said that they were unable to see the lens and the left eye was normal. They wanted us to rule out chronic end-stage uveitis or neoplasia. All right, this globe's a little bit difficult. So here's cornea. This part we know for sure. This is actually probably lens. So that's a little bit nice to have one thing we can identify. This is probably iris. This is probably an iris leaflet. And then after that, it gets a little bit difficult. So there's definitely some soft tissue in the anterior chamber. There's definitely some hemorrhage in the anterior chamber. And then, what's that? I know there is iris bombae, but I can't tell confidently what part of this is iris and what part of this is hemorrhage and part of this is mass. So Gillian wants me to say there's iris bombae. She's right, but I can't tell you which parts of this are iris on this side of the globe. I'm open to, can you tell?
Yeah.
Okay, Gillian's gonna show you.
That leaves the fingertips open.
The iris, here's ciliary body, the iris is plastered against the cornea and it comes back. So this is posterior chamber right here.
So how can you tell that this is iris and this is membrane?
Maybe it was more
Just-
obvious grossly, and I was the one who grossed it.
Okay,
So there.
that's helpful. Okay. And then we have all of this tissue, sort of posteriorly. This is optic nerve. This is probably detached retina. And then here, this is this is presumably the mass that they were describing clinically, that they were most concerned about.
Well, it's interesting because they said there were masses at both sides. And so I think they were seeing the iris bombay on one side and the actual mass on the other. There we go.
Probably. All right. Here's the mass that we saw grossly as being that big tan blob. Cornea is up here. I'm gonna put the mouse in the middle, so I'm not driving this around on the side. So here is the iris that Gillian described as being iris bombay. So ciliary body back here, iris following along the contour of the cornea, and then adhering to the lens. And then there's all of this tissue also that's coming off of the mass and is also adherent to the lens and is kind of smearing onto the iris leaflet that is adhered to the lens. There's some hemorrhage that's trapped in this space. There's a little bit of proteinaceous goop. Here is our detached retina that we were able to appreciate grossly. So this little thin cord of tissue is detached retina. And then the lens doesn't look great. It has become a little four-leaf clover. And the nucleus is kind of fragmented. That's not all artifact. From this magnification, we can't say a whole lot about the lens capsule, but we are beginning to develop concerns. And then the other thing is that the choroid is really, really cellular, sort of extensively, kind
It's
of
like a retina.
almost circumferentially,
Retinoid.
the second retina. And so that's a problem, and we're gonna have to look at that. All right. So here's our cornea. Here's this layer of cellularity posterior to the cornea that might turn out to be a problem. This is that space that we saw that was being created by this iris that is sneakiated to the lens with iris bombay. There's all this hemorrhage. And then there is also this increased cellularity sort of blanketing the lens that is mostly also effacing this iris leaflet. The lens capsule, really, really wrinkly. If we go back here, here's lens capsule. It's incredibly convoluted. I don't think in her report, she described any lens capsule rupture, but based on the entire story that we're putting together with this case, we speculated that it might be present and just not in the plane of section. The lens itself, all of the lens proteins the lens fibers are becoming fragmented. There's liquefaction. So you have kind of sort of normal striated fibers here, and then they become broken up and irregular and sort of this homogeneous goop. So there is a hypermature cataract. And now,
Before you move away from the
Gillian
lens,
wants to
go
look
to
at
the
this.
anterior lens capsule, kind of on the opposite side. And go down.
Here,
Keep going. Now go down.
like this way.
Yes.
Okay.
Keep going
Okay,
to the other pole.
okay. We're going all the way to the top.
It gets basophilic in that spot. Right there.
Oh, okay, here we go. So here we've got some invasion of the lens capsule by some inflammatory cells. Some of, oh, maybe they're not inflammatory cells, just kidding. I thought that they were inflammatory cells. This might not be true. There's some fragmentation of the nuclei. There's some pycnosis and karyorrhexis. But some of these cells are perhaps not actually inflammatory, in which case I'm going to save them for later.
Okay.
And later's actually right now, but that's okay.
Yeah, the only thing I think is important about that is that infiltration of cells into lens caps and fraying of the lens caps and fibers, kind of like string cheese, you know, when you pull it apart. Usually, I don't think it mostly happens when there's lens capsule rupture. So that's
They
another
have to get
marker.
there
Yeah,
somehow.
exactly. That's
Yeah.
another marker for lens capsule rupture.
Yeah,
They're not just gonna like punch through the lens
Exactly.
capsule.
Yeah, the lens capsule is really, has a lot of fortitude against a lot of things, but if it's ruptured, then the cells will infiltrate into it and fray it.
Okay, so this is our very large mass that is effacing the iris. And the mass is composed of these cells that are kind of radically atypical. So they are, Gillian wants me, we're gonna go on this magnification first, then we'll go higher, Gillian. So they aren't making any sort of particular pattern. There's areas where they're kind of streaming like this. There's areas where they're more in sheets and there's no particular pattern at all. Some of these cells have multiple nuclei. Some of these nuclei are enormous. Some of these cells have mitotic figures. Now that I've gone higher, I'll never find it. There's one. Some of these cells have mitotic figures. Some of these mitotic figures look strange. Maybe some of these cells are dying. So there's some kind of extremely atypical neoplastic cell population. And this cell population also extends into the choroid with that sort of hypercellularity that we saw on subgrowths. So this is that same population going back into the choroid. And then we've got our retinal detachment, and these cells are even kind of lining the surface, the outer surface of the detached retina. And all things considered, the optic nerve is actually not doing too terribly. With this particular condition, sometimes we talk about spread of the neoplastic cells along the optic nerve, which has more grave prognosis, and that's not present in this case, which is better for Blackie, I suppose. There's one more thing that we described, I think it's on this side, yeah. So here, this is that same neoplastic population, and they're surrounding a vessel in the sclera, and they're replacing the tunica media of this vessel. So there's no tunica media anymore. There's some endothelial cells that are hanging on. So it probably hasn't actually invaded into the vessel itself, although there are places where you could argue, you know, where is the endothelium here? And are these cells blebbing into the vascular lumen up here or up here? It's hard to say. If this hasn't invaded into the vessel, it sure wants to. Okay, so this was post-traumatic sarcoma. It was spindle cell variant, and we said there were clean margins. This is something that we associate with trauma to eyes, particularly in cats. I think every once in a while we describe it in another species, but it's extremely uncommon. Usually there is trauma to the lens capsule, and we think that these cells are arising from lens epithelium. We're working on an IHC project to try to demonstrate that. There is also a round cell variant, which may actually be arising from inflammation rather than the lens epithelium itself. But this is something that clinicians a lot of times will take an eye out from a cat that has experienced trauma, especially if they think there was trauma to the lens, sort of to try to prophylactically prevent the development of a post-traumatic sarcoma. It usually takes a long time for this to develop. A lot of times it'll be like 7 years after the traumatic event when we receive the actual globe. And,
Somebody's asking a question.
oh, okay, that's fine. Yeah, so, we have a lot more cases to get through, so I'm gonna be done with mine. And I'm gonna swap with Megan. Our next case is Ben. Yes. So Benny is an 8-year-old mixed breed, neutered male dog. We have a globe that was ophthalmic. There was diffuse corneal edema. In the anterior chamber, they described fibrinous inflammation, and on the lens, fibrin on the anterior lens capsule, which they said likely cataract. So there was something going on in the anterior chamber, and it was probably hard to see inside the eye with lots of corneal edema. But we'll find out some more things about that. Another thing that is interesting about Ben is that he had a fever of unknown origin and left forelimb shoulder lameness with intense pain. He also has a large caudal lung mass. So that is sort of the history that is pertinent, I think. And here is the hemisected globe. So we do indeed have a sort of thickened and cloudy cornea. But the main thing as we go back from the cornea that I would want to draw your attention to is the stuff that they probably interpreted as or looked like fibrin on the clinical exam. We have the nice thin band of brown, which is the iris leaflets on each side in the middle. And
Speak
then
up, Megan.
oh, speak up. And then surrounding that, there is this halo or thick carpets of sort of white tan tissue, completely surrounding the iris leaflets on both sides. You can kind of make it out on the lens capsule surface too. And one thing I'll also draw your attention to is right over here on the surface of the choroid, this little button of similar tissue right there. So there's some suspicious sort of carpeting inside the eye. There is also retinal detachments with this little blush of hemorrhage in the vitreal space. All right, let's switch to the histo. So this carpet that was sort of white tan grossly is disturbingly purple on histology. There's lots of cells here in this carpet, and it is on both sides of the iris. And there is also a similar cellularity to this cute little button, which was nicely captured on the section for histo, as well as what we can see on the gross. Let's take a look. So now we flip it around here. Just to help everyone maintain orientation, this is the same way it was on the subgross there. So we have this really thick carpet of cells, and looking closer at who these guys are, they turn out to be neoplastic. And the interesting thing about these cells is that they are spindle shaped, and they are arranged into these haphazardly intersecting streams. So this is a sarcoma or mesenchymal neoplasm. And this carpeting behavior is very interesting. It actually doesn't infiltrate the uvea all that much, maybe a little bit, but it looks more like it's on the surfaces of the globe. And this carpeting behavior is one of the features that we associate more strongly with metastatic disease, rather than a tumor that would have arisen within this globe. Certainly another finding that can indicate metastatic disease, or at least supports that conclusion, is if there are cells inside vessels, which I can't show you on this case. And of course, rules, especially in biology, are not necessarily going to be hard and fast. You know, cells inside vessels can be arriving at the globe too, and carpeting behavior doesn't always mean metastatic disease. But these are features that are suggestive of metastatic. Let's take a look closer at this little button of cells, which is again neoplastic cells. They do sometimes round up and become almost kind of epithelioid. And they have eccentric nuclei in some of these areas. You can see all these mitotic figures here. Look at all these mitotic figures that jump out as soon as you get close to these cells. And you can kind of maybe imagine that these cells have a bit of a perinuclear kind of clearing, like maybe they're being a bit productive. And right here, these cells are associated with just a tiny amount of extracellular eosinophilic matrix. It's rather glassy and homogeneous and a little bit faintly staining. And there's lots of things that can make this appearance inside the globe. A little bit of vascular permeability, you get some protein leakage, and this could look like that. You could maybe cross your eyes, you can maybe squint and imagine that this could be produced by these cells. It's not really classic for osteoid, and we certainly did not describe this as osteoid in our reports, but there are some features of this case. The general appearance of some of these cells, the history of shoulder lameness and a lung mass that were suggestive enough for us to put osteosarcoma metastasizing to this globe pretty high on our list of differentials. Just to kind of finish up the distribution of these cells to the carpet on the uvea and that little button on the choroid were the most impressive, but there are also similar cells forming these strands in the vitreous. They're kind of getting around inside the subtype. Those are the features that I would point to as being the most salient. There are, of course, a lot of other things to see in this globe, cataract and some corneal disease and things like that. But the tumor was the biggest thing to show you. Okay, and yes. So we diagnosed this as a poorly differentiated metastatic sarcoma. We had that metastatic osteosarcoma as one of our top differentials. And then we also, because of that rounded appearance and some degree of pleomorphism, put histiocytic sarcoma on the list. And then you always have to put melanoma on the list, it seems, for any tumor that has this variable morphology. Sometimes melanoma can look a little bit more epithelioid, sometimes a little bit more spindle shaped. So it was worth putting that on our list of differentials as well. We haven't pursued any further IHC in this case to try and narrow it down, and a couple other sort of more minor findings as compared to this tumor in the eye as well. So that is Benny's case. All right, we'll do the next one. This next one is a dog named Sage, a long-haired dachshund, 6 years old and neutered male, who hails from Illinois, Chicago, Illinois. And I will mention this in particular because it does have relevance. So they describe glaucoma in this case, uveitis, hypopion, and a superficial corneal ulcer. And there was, well, I think we already said there was. So the retina is detached in this case. You can kind of make out the edge of the retina along here, this sort of slightly more opaque tissue. And then underneath the retina, there's all of this tan material, as well as this lighter sort of jelly-like material beneath that. Same thing in the anterior chamber, there's sort of a gelatinous off-white material. So there's lots of very protein-rich and probably very neutrophil-rich exudate inside this globe. And retinal detachment. So that is all for the gross. Let's take a look at this. Who's first? Switch over. All right. So most of what's going on in this globe is in the posterior segment. We do have a little bit of protein, just like we saw in the gross, with that sort of gelatinous fluid. It translates histologically to this eosinophilic, glassy, sort of protein-rich fluid in the anterior chamber. But most of what's going on is in the back. We do have a retinal attachment, and in particular, a really, really thick subretinal suppurative exudate. Flip this around and look at the indication. here we are in the back again, retinal detachment again, and the subretinal exudate. And I'll go closer to prove to you that it is indeed mostly variably degenerate neutrophils, probably a little bit of fibrin in here, so the suppurative exudate back here. Look at all those neutrophils. Lining the surface of the choroid, probably going too fast and close. A little closer one. There is variably thick carpeting by these big plump foamy macrophages. So basically the whole eye is almost like one giant pyogranuloma in some ways. And when we see a distribution of inflammation and a character of inflammation like this, we're thinking fungus. And actually there's probably one about to come into the field in a hot second there, but I have a favorites, which should be up here. Ha ha ha. Hello, favorites. There's plenty of examples, but I like this one. It's cute. Ah, put you right in the middle. Right, focus. So here is an organism. This is a yeast organism, and it has a round shape. This one is probably just beginning to bud. We have this little button of broad-based budding, lots of bees there. And we have a nice big basophilic nucleus to it. And then it's surrounded, the reason why I like this, and it's one of my favorites in this globe, is it's surrounded by this interesting reaction along its surface, which is a sort of mohawk of basophilic material that forms these club-shaped projections. And this is what splendory Hopefully phenomenon tends to look like when it's in the vitreous. It tends to take on a more basophilic appearance in the eye. For whatever reason, often in other tissues, it's more eosinophilic club-shaped projections. But either way, it's a similar process, or thought to be a similar process of immune complex deposition and things like that on the surface of an irritating antigen inside the tissue. So this is the yeast organism that's exhibiting broad-based budding. This is blastomycosis, probably blastomyces dermatitis. And in a dog from Illinois, so it kind of checks all of the boxes. So we showed a lot of the different yeast organisms that you can find inside the eye. This one is a pretty classic one, but I figured we should, since we showed all the other yeasts, show this one, especially given that we're broadcasting from Wisconsin. This is sort of our local flavor here of yeast. This is blastomycosis in the dog, the eye of a dog. We presume that this dog had a systemic infection, so they'll want to go for some further workup on this case for sure. And again, some kind of other things going on, the retinal detachment, and there was some uveal inflammation, things like that. But the yeast is the most fun thing to show you. All right, that is that case. And with that, I will hand the floor over.
Alrighty. Next up is Tristan, a 4-year-old Siamese cat. History of eyelid agenesis, corneal disease in both eyes, central corneal leukomas, which is basically a white spot in the center of the cornea, in both eyes as well, immature nuclear cataract, and lens malformation in both eyes. Eyes were removed for comfort and to avoid post-traumatic sarcomas because they were worried about lens capsule rupture. Both globes had scleral fibrosis dorsally with extra tissue. Yeah, actually, that ended up being irrelevant. Let's see here. Mostly they were worried about the post-traumatic sarcomas in these eyes. So we actually got both eyes from this cat, but I'll just show you one. So this is the right eye. And on the gross photo, you can so here's cornea at the top. It's a little bit brown on the surface. That might be vascularization or pigmentation. I'm not sure which. You can see that the lens is oddly shaped, and it has its anterior pole is sort of reaching up toward the cornea. It's cone shaped. So we call this lenticonus. And so you can see that little sort of button up there reaching up toward that spot in the cornea. And then in the back of the globe, we have this little wisp of whitish tissue extending from the posterior lens capsule back toward the fundus. The retina is actually still in place here. So the retina is, so this is not retina right here. And then let's see here, the choroid is poorly pigmented. And they actually reported that this eye has this cat has blue eyes. But when you look at the iris, it's actually quite brown. So I think there's some reactive change happening on the iris there. So that is the gross photo, and unfortunately, the histo is not quite as beautifully put together because of artifacts in embedding and sectioning. But we'll go ahead and show you what we have here. All right, so here's our cornea to the left, looking pretty boring from this magnification. There's a little bit of basophilia here, which is some, I think, vascularization and some inflammation. We'll take a look at higher mag. Unfortunately, we didn't sample that little button of lens that was extending anteriorly. There's a bit of a cataract, and unfortunately, we also didn't sample that stalk of tissue that was extending from the posterior lens capsule. But when we move back to the optic nerve head, there is actually a little stalk of tissue extending from the optic nerve head right there. And as I said, the retina is actually in place here. So let's go see what we see here. So the corneal epithelium is absent over part of this cornea, and it's very attenuated where it is present. So there's an ulcer, which helps to explain this vascularization of the stroma. And we have a few inflammatory cells in here. Some neutrophils, and some other, maybe a few lymphocytes and plasma cells, but not a really severe keratitis there. But anyway, so when we move more axially, we get to this little blip right here in Descemet's membrane. So you can see the Descemet's is present here. And then as we follow it, all of a sudden it's not present, sorry, on the back of the cornea anymore, and actually does this sort of curl inward, and it sort of blends with this collagenous tissue. And we're going to move along. So in this area here, Descemet's membrane is absent, or it's very, very thin. So there might be some regrowth in this area. And here we get to the other side of that defect, and you can see this little curl of it again. So I think that this actually was reflected onto the surface of the lens. Unfortunately, we didn't catch that in section. The other globe actually has a better example of that. Maybe I'll show it real quick, probably in a few minutes. So the lens, let's look at the iris real quick. So they reported blue eyes in this Siamese cat, which is understandable. I think most Siamese cats have blue eyes. But there's actually quite a bit of pigments in this iris. So I think this is more of like a reactive pigmentation than a neoplastic change. But I think we did list a differential of an early feline diffuse iris melanoma or melanosis. And then, what's that?
How do you tell the reactive?
It's really hard.
Because it looks to me like exactly what we would call early fitum.
Yes.
Clients and those early fitum.
Yeah.
Early fitum.
Yeah, you could probably call this an early fitum. So feline diffuse iris melanoma, because there are cells on the surface and also in the stroma. Right here, we would consider that to be invasion, and therefore we can call it an early fitum. Feline diffuse iris melanoma. That's our abbreviation of that term. So moving along to the posterior lens, which is unfortunately fragmented. When we get closer here. The lens capsule is very thin. Let's see if I can find it in here. Here it is. It's very wrinkled. So there's a little bit of posterior lens capsule wrinkling, and there are lens epithelial cells lining the interior of it. So we have posterior migration of lens epithelium. So that is at least a posterior subcapsular cataract. And unfortunately, we didn't sample the rest of the lens very well. Here is some peripheral retina. This is an artifact that is present right here. But as we move backwards, we get to the optic nerve head here, which is quite recessed and gliotic and atrophied. So we've got some degeneration of that optic nerve. And then we have this stalk of collagenous tissue with a blood vessel in it, extending up from the optic nerve. So this is the hyaloid artery, and it is persistent because this is, after all, a 4-year-old cat. So this and the fact that it reached up toward the lens, at least grossly, is consistent with at least a persistent hyaloid artery. One might call it a persistent hyperplastic primary vitreous as well, or PHPV, which is a good congenital, rare congenital problem in animals and people. The rest of the retina was fairly normal. I don't think they actually haven't reported glaucoma, so I don't think there was actual glaucoma, despite the fact that the optic nerve looks quite atrophied. So let me throw up the other eye real quick just to show you what its lens looks like. It was a slightly better example, although I think the lens is embedded backwards, but yeah. So here's our cornea here. We have that same blip of Descemet's membrane absence axially. And so this actually corresponds to the leukoma that they reported clinically. And that leukoma is probably due to some stromal fibrosis associated with the break-in or the absence of Descemet's membrane there. So here is actually the anterior aspect of this lens, and you can see how nose-shaped it is. It's cone-shaped. So this is the lenticonus. And actually, this one has the bit of Descemet's membrane stuck to it. Right here. So this one did not have the same, oh yeah, this one, unfortunately, the back of the sclera had been cut during surgery. So we couldn't confirm that presence of that persistent hyaloid artery in this case, or in this eye rather. Okay, so let's go on to our diagnoses. So this eye has multiple congenital anomalies, and actually both eyes did, that were presumed congenital. As I said, this one had iris melanosis / early feline diffuse iris melanoma, the lenticonus with the nuclear cataract, and also cortical cataract. We listed differentials of a congenital or juvenile cataract. There was this axial Descemet's membrane defect, which is characteristic of Peters anomaly or anterior chamber cleavage syndrome in humans, also under the umbrella of anterior segment dysgenesis. Oh yeah, the iridocorneal angle was recessed on one side. So we thought this could have been part of anterior segment dysgenesis, the way we define it in veterinary medicine, which refers to specifically the malformation of the iridocorneal angle and the drainage tract of aqueous humor. Post-lenticular collagenous plaque and vascularized collagenous stalk from the optic nerve head, and we DDX persistent fetal vasculature or persistent hyperplastic primary vitreous. So this cat also had eyelid agenesis, and so presumably, unfortunately, it just had bilateral eye developmental anomalies leading to issues, and it was uncomfortable, so they decided to enucleate both eyes. So that is the story of Tristan. All right, last case of the day. This is Shelby. Shelby is a 10-year-old Labrador Retriever with a history of uveitis of the right eye, which is this one, and secondary glaucoma and keratitis. This dog also has history of periarticular / articular histiocytic sarcoma, left of the left shoulder joint, and had a left forelimb amputated in June of 2022, so just a couple months ago, unfortunately. So that probably prompted the gross photo in addition to this interesting looking gross appearance that we have. So here's the cornea at the top, it's quite opaque. And then the anterior segment and anterior chamber are effaced by this solid off-white to brown mass. Some of this brown, like up in here, is probably hemorrhage. Some of the brown that's a little bit more at the back of it is probably remaining iridoid stromal melanocytes. The lens is very red. I think that's actually the color that it was, because I think there's actually lens capsule rupture, I think, in this one. Anyway, and then there's hemorrhage in the posterior chamber and vitreous and subretinal space. Here's the detached retina. And that's about it. And otherwise, the globe is very oddly shaped. And whatever that tumor is extending into the ciliary body at this side of the globe. So there's the cornea. Here's our mass that is quite purplish pink. So it's pretty densely cellular, and it's expanding the iris, filling the anterior chamber. It also extends into the limbal sclera and peripheral cornea right there. Arrow in the middle, it is extending along. It's carpeting the surface of the ciliary body as well as infiltrating into the stroma. Here's our sad lens. There's a cataract. More of the same on the other side. And then there's the detached retina with a little bit of hemorrhage. So let's go ahead and jump in. We're going to look at the cells in this area of the ciliary body because they're all pretty viable here, not necrotic. From a slightly lower mag like this, the cells are not really making any particular patterns, so some maybe haphazard bundles and streams, which is good for sarcoma or mesenchymal tumor. And when we get higher mag, those cells are spindle shaped with variably distinct cell borders, moderate amounts of fibrillar amphiphilic cytoplasm, and oval to elongated to irregularly shaped nuclei. There's quite a bit of atypia present, so some nuclei are larger than others. Here is a multinucleated cell here. There's another one here. So those cells are also quite large. So we have some what's megalopsychosis. Here's another example of a really big nucleus. So we've got some really pronounced cellular atypia, anisocytosis and anisokaryosis. And with the handy history of a histiocytic sarcoma of the joint, we concluded that this was also most likely a histiocytic sarcoma. Some of these cells do have some pigment in their tummies. Here's some. But remember that histiocytes are professional phagocytes. So it's quite possible that they are picking up and phagocytizing pigment from some destroyed melanocytes of the uvula. Here, there was a nice mitotic figure right there too. Ooh, almost on the edge there. So these cells are also mitotically active.
Without the history of the joint histiocytic sarcoma, would you be able to rule out melanoma just based on some morphology? Okay.
Nope, not at all.
Mhm.
So yeah, we would definitely put those both as differentials and suggest probably at least the CD204, which is a histiocytic marker that we have here at UW, if not also a melan A, to bang both of those out at the same time. The question was, if we hadn't gotten the history of the histiocytic sarcoma, would we have included something else on our differential list, such as a melanoma? And the answer was yes. So anyway, we're back up here in sort of the anterior segment, or anterior, well, this is the iris, formerly known as the iris. Just to clean up our cleanup points here, we've got some pretty pronounced epithelial hyperplasia of the corneal epithelium with some keratinization on the surface, which is common in ophthalmic globes that have increased exposure of the corneal surface. And then the corneal stroma itself is hypercellular. So these are probably either reactive keratocytes or fibrocytes or fibroblasts in the corneal stroma. There are no doubt some blood vessels around. There's one right there that I happen to land on. So there's stromal fibrosis and vascularization, which once again, all goes along with increased exposure of a ophthalmic globe. Here's a break in Decimase. This could be due to either ophthalmos or blunt trauma. And in this case, we might propose blunt trauma to a blind eye, because presumably this eye has been blind for a long time. So these cells do really extend right into and efface the limbal sclera. I'm trying to figure out why the lens was looking so red grossly. Maybe it was a puddle of blood on top of the cut surface, but anyway, here's the posterior aspect of the lens. So we've got a very thin posterior lens capsule, which is what it should be. And then we've got lens epithelial cells lining it. So we have posterior migration of the lens epithelium, which is one of the hallmarks of cataracts. And then also here's still intact lens fibers. And then between here and here, the cortical lens fibers are liquefied. So there's cataractous degeneration there. And then in the, actually, I think that's some lens protein. There's a little bit of lens protein that has leaked out of the intact lens capsule. And you can compare and contrast those little blobs to these little red blobs, which are red blood cells here. These might be some native histiocytes of the globe, or they could be some neoplastic cells on vacation. And that's about it. Really, we have, let's see here, there's a little bit of hemorrhage in the posterior chamber here. And then as we travel back, here's our detached retina.
I have a question. On the chat, for Clarence asked if you could mention the features that differentiate the primary versus a metastatic neoplasm to the eye. I think that one's case.
Yeah, so this one is actually kind of hard. So normally we look for carpeting of neoplastic cells on uveal surfaces, and or finding them in blood vessels around the eye. This one's pretty hard because it is truly effaced. It has infiltrated the entire anterior uvea and effaced it. And that is something that a primary ocular tumor can do as well. So honestly, so here's some maybe more convincing carpeting on the ciliary body surface. However, without the history of a previously diagnosed histiocytic sarcoma, we would definitely want to list differentials of a primary intraocular tumor. Highest on the list would probably have been a malignant melanoma. And then histiocytic sarcomas, I think, are a little bit mysterious. We don't actually know if they all end up in the globe due to metastatic disease or if they ever develop in the globe. What we do know is that when we diagnose a histiocytic sarcoma in the globe, the prognosis is quite poor, and the average survival time after that point is about 3 months. But we don't really know whether it's because the dog already had systemic histiocytic sarcoma somewhere else, or whether it metastasized away from the eye and caused the systemic disease. So it is a bit of a mystery. I'm not sure how we'll ever get to the bottom of that. So I think those are all the salient features of this case to show via the microscope. So here we go. So our first differential was, our diagnosis was really a metastatic histiocytic sarcoma. We did DDX, a malignant melanoma, but honestly, with the history, we would just assume that it's a histiocytic sarcoma that's associated with the dog's previous excision. It was completely excised, which is good news for local disease, at least. So there was ophthalmos and vitreal degeneration. There was an indolent corneal ulcer, which I failed to show you. I can't remember where it was. There was a cortical cataract, mild intraocular hemorrhage, diffuse retinal detachment, and chronic secondary glaucoma. So that is all I have to say. Anything else? Okay, thank you for joining us for rounds today. We will try to get this video uploaded to YouTube by the end of the day, and then it will be available for more viewing pleasure.
You guys in 2 weeks, or some of you guys next week.
Do you have some students? I forgot that I have rounds today that are mandatory. Do you guys need an extra hour of time?
Or we got
Emailed out to you guys we got the history for our one case study today, it's the dog that was with him tomorrow, and then like didn't show up and stuff. And then pick your Wednesday assignment, like your presentation for next Monday, pick a topic for that, so you know, both of us. And then, I think I'm still missing one report.